Good afternoon, everyone, and welcome to the Wilmot Cancer Institute Community Conversations on Cancer series, sponsored by the Office of Community Outreach and Engagement and its Community Cancer Action Council, or CCAC. I'm Jason Coleman. I'm the Associate Director for Cancer Center Partnerships at the American Cancer Society and the co-lead to the Access to Cancer Care Integration CCAC work group. I'd like to thank you for joining us for today's community conversation on cancer. The title is Skin Cancer, Risks, Prevention, and Emerging Research. Community Conversations on Cancer is an educational series designed to inform, educate, and disseminate best practices in cancer research, clinical care, and community engagement. Over the course of the series, topics will address the social determinants of health, improving cancer care delivery, and promoting health equity across the 27 county catchment area for URMC. This live event has been approved for 1 AMA PRA Category 1 credit, 1 CNE credit for nursing, and 1 contact hour for social workers. Our presentation today will be followed by a question and answer session. Throughout the presentation, please feel free to enter any of the questions that you may have in the chat. We will be monitoring that, and we'll address those questions at the end of the presentation. So now I'm pleased to present today's presenter, Dr. Peter Prieto. Dr. Prieto is a triple board certified surgical oncologist in complex general surgery, surgical oncology, general surgery, and medical quality. He completed his residency at Yale University, an immunotherapy fellowship at the National Cancer Institute, and a clinical complex surgical oncology fellowship at MD Anderson Cancer Center. Dr. Prieto has been instrumental in researching treatment options for melanoma and has received several awards for excellence in research. He's a native of New York and has a personal mission of treating all of his patients as if they were his own family. So at this point, I'd like to turn it over to Dr. Prieto.
Thank you for that kind introduction. I'm going to share my screen and talk to you today, kind of getting towards the tail end of May. It is Skin Cancer Awareness Month, so it is very timely. We're going to talk about different types of skin cancer today, some prevention, and really kind of cutting edge research. This disease, which has especially changed over the last few years, and I'm often practicing medicine now that didn't exist when I was a trainee. So it's been very exciting. As mentioned, I was at the NIH for 3 years in the middle of residency, where I was part of a team that developed the first immunotherapy for patients with metastatic melanoma, and that was anti-CTLA-4, what we'll hear about a little bit later, now known as Yervoy or ipilimumab, and that field has exploded. And thanks to my mentor, Dr. Steven Rosenberg, who was up here actually a few years ago, pre-COVID. We'll do some background today. We'll talk about kind of the surgical approach to treating skin cancer, and then we'll go into immunotherapy, which I think is fascinating. Skin cancer and melanoma in particular is kind of the forefather of treating cancer by harnessing the body's immune system. So, and that has only had broader and broader indications throughout the years. And then we'll get into some cutting edge therapy or research we've been doing here in Rochester over the last few years. So what I like about skin cancer and surgical oncology, it's multidisciplinary. You know, the rings overlap here. And every cancer should be treated in this way, from a multidisciplinary approach. Often 4 brains are better than 1. And I say to my patients, this is a constellation of care that comes together with the help of dermatology, medical oncology, surgical oncology, and radiation oncology. And that's what's very satisfying for me. As mentioned, I have a personal history. My father was a patient with the diagnosis of a pretty rare sarcoma, but that kind of motivated me to try to make a little difference in this terrible disease, which I think we're making some progress, especially in skin cancer. Unfortunately, melanoma is on the rise. It's about the 5th most common cancer now, men and women. It has decreased slightly in incidence last year. We think maybe related to decreased exposure to primary care dermatology visits due to COVID, but it had been on the rise for years, unlike other cancers, which we had seen a decrease in incidence. It's a minority of skin cancers, but it accounts for almost 80% of deaths from skin cancer. So it's a real problem. It's a real problem in places like Rochester, where the sun feels good. We don't see it that often, although this week has been great. So there are neurotransmitters that are released when you go in the sun after being in a week of clouds to tell your body, to tell your psyche that this feels good. There's a feed forward system. So it's understandable. The risk of developing melanoma has steadily increased. And you can see from the 1930s to the 2000s, about 2020, it was about 1 in 40 patients will get melanoma. Let's put that into perspective. So about 1 in 7 women will get breast cancer now. About 1 in 5 people will get some form of skin cancer, but about 1 in 40 will be melanoma. So again, we're seeing a rise in skin cancer. Melanoma is the most deadly of those cancers because of its ability to spread. And again, this is a cancer that's on the rise. It is outpacing other cancers. Again, last year excluded, but you can see through these kind of swimmers plots where we're seeing a decrease in oral, stomach, and cervical cancer on the bottom left. Melanoma is outpacing other cancers. And why is that? Well, as I mentioned earlier, the sun feels good, and it feels good in Rochester. And you can see a picture here from the 1980s in the right corner, and the left upper is, I think that's Coney Island. And the reality here is we have an addiction to the sun, and there's a generational experience with appropriate sun blocking barrier methods. I didn't wear any sunblock. I was a lifeguard myself, and that's concerning. Now, often we see patients wearing hats, going out with sunblock. Children have long sleeve bathing suits, regardless of gender. So times have changed. These other exposures to radiation exposure, UV radiation exposure, are unfortunately preventable, but very, very prevalent. So this is a tanning bed. And the WHO, the World Health Organization, actually classifies tanning beds as a carcinogen. Yet there are probably about 3 or 4 in Penfield alone. There's state-to-state legislature that's trying to make a stance against these, and again, we're doing that state by state, but hopefully in time. And some of these centers, some of these tanning centers are moving more towards kind of spray applications, which are generally pretty safe, but tanning bed use comes with well over an 11-fold increase in your risk for getting skin cancer. I use this term tanorexia. We see it all the time, and it always bewildered me because you can see on the right here, there's a fictional, this is from a movie in the 1990s. We see a bodybuilder here, very, very tan. But this is what skin looks like after decades of sun exposure. We can see lots of sun damage here. This patient ended up having a melanoma here, but these are all keratosis. These look kind of ugly. They're waxy, they're benign, but, and this is actually a fairly large blackhead, but you could see again, why, if you put skin cancer aside, why people don't avoid the sun just for cosmetic reasons is unbeknownst to me. Your skin does not like to be in chronic exposure to UV radiation. So let's start with melanoma. Risk factors for melanoma, family history. If you've got a first-degree relative with melanoma, your risk is much higher. If you kind of meet this kind of phenotype, we say, or red, freckly, if you have had multiple moles biopsied, if you've had multiple blistering sunburns, before the age of 20, that's something to consider. And if there's mutational kind of hereditary cancer syndromes that are associated with an increased risk for skin cancer, and in particular melanoma, P16 is one of them. MITF is another. But these are things that we can often screen for if we think there's a family history. This screening should be based on an individual person-to-person evaluation for their true risk. Generally, not everybody needs to see a dermatologist, but if you're coming from a high-risk phenotype or family, we do recommend that you get into your dermatologist for what I say, a toes to nose skin evaluation. This is crucial for looking at kind of, or determining what are changes that we think are suggestive or suspicious of melanoma. We call these kind of the A, B, C, D, E's, and a lot of them make sense. And the most important is actually the E, but let's start at the top. So asymmetry. So lesions that are asymmetric, right? Typically, again, and these are not hard and fast. These are not gospel. These are guidelines where we say an asymmetrical lesion, start to think, well, maybe there's something different about that. Are the borders irregular? Is there heterogeneity or inconsistent pigmentation? Are some parts darker than others? Is it large? You know, size sometimes does matter in the context of looking at changes in lesions on the skin. But most importantly, it's evolution. It wasn't there a week ago. It's there now. It's changed considerably. That is something that is most commonly reported. A lesion has started to bleed. It started to grow, etc. Not all melanomas, and these are all melanoma, not all melanomas are pigmented or black. You know, on the bottom right here, this is an amelanotic melanoma, and those often present later, as you would expect, because guess what? People don't have it kind of in their mind that this could be a melanoma. And also about 25% of melanomas arise from pre-existing moles. So that's 75% that don't come from moles. So it's not always a mole that's changed or had UV exposure decades ago. We see de novo melanoma just arising from melanocytes, and I'll explain kind of what that means in a little bit. But types of melanoma, there's your cutaneous, your skin, you know, superficial spreading, nodular. There's acrolitiginous. This is rare, but accounts for about 3/4 of melanoma of people of darker skin. This is typically your soles, palms, nail beds. Ocular melanoma is more rare and a really awful disease in the sense that it almost always spreads to liver and often presents very, very late. And mucosal melanoma is the most rare, and this, again, can happen anywhere, as I say, from mouth to anus, sinuses, vaginal, mucosal surfaces are all throughout the body, small bowel. Melanocytes are everywhere. They are the pigmented cells of our body that change when we get exposure to sun and we tan. They help us tan. They live somewhere between the first and second layer of the skin. The first layer of the skin is the epidermis, then you have the dermis, then you have the hypodermis, and the melanocytes live somewhere between the epidermis and the dermis. And when they become cancer, those melanocytes turn into melanoma. Acrolitiginous melanoma, again, soles, nail beds. If you see a linear pigmentation in your nail bed, or you see some pigmentation within your mouth, on your cheek, something new, again, things to consider. Get seen by a dermatologist, and they will decide. Often these are very, very smart doctors, and I work very closely with them, and every single one in Rochester is absolutely outstanding, and they will get you to the person that you need to see, whether that's a surgical oncologist like myself, a head and neck surgical oncologist, or a gynecologist. It's a great community for cancer care in Rochester. Prevention's key, like many diseases. Prolonged UV exposure, you know, boats, beaches, parks, driving, golf. Sunblock is not, and this is an important message that I cannot stress enough. Sunscreen is not permission to sunbathe. And for some reason, people think that sunscreen allows you the ability to lay out, as they say, and it does not. Nobody on this planet should sunbathe. We all should go in the sun. We should enjoy our lives. We should be on sailboats. We should go to the beach. We should go on vacation. We should be in swimming pools, but nobody should lay out. And sunscreen is meant to protect you when you're ambulatory, when you're walking, when you're on a sailboat, when you're walking around, when you're in the pool. It's not meant to be a protection or a bulletproof vest against skin cancer So I think that's an important point. That's how deadly UV exposure is. I generally recommend at least 30, but I don't usually go above 50. The difference between SPF 50 and 70 is minuscule, and I don't think there's any benefit. About 50, SPF 50 blocks about 97% of harmful UV radiation, and SPF 70 blocks about 98. So you're not getting much bang for your buck there. We use mineral based, we recommend mineral based sunscreen, typically easier on the skin. It gets a little pillier, but, and reapplication is key here. So don't just put it on once and say, I'm done. If you're bathing, especially if you're in the ocean, you need to put this on every couple hours. Long sleeves, hats, playing golf, put that hat on. And one of those nice desert hats that has something to, or a long brimmed hat in the back that covers your neck. Not all cars, driver's side windows, sometimes you see people with their arm hanging out the window, right? Not all glass blocks UV radiation. And in fact, most does not. So don't think that there's a barrier there. As melanoma gets thicker, and we classify melanoma by its depth. So the deeper the melanoma on diagnosis, and there'll be a biopsy done, this will get sent to a dermatopathologist or a skin pathologist, and they will look at that under the microscope and they'll measure how deep a melanoma is in millimeters. The deeper the melanoma, and it makes sense, the more likely it is to spread. And I think of melanoma as kind of roots of a tree. As that tree establishes itself, those roots grow down and out. That's kind of what melanoma does. The deeper the melanoma, and you can see here in this chart, over 4 millimeters comes with a over 50% chance of having a lymph node be positive with an ulcerated melanoma. And what that means is that the deeper the melanoma, the higher the chances to spread already to the lymph nodes. And most melanomas do spread through lymph nodes, not all, but that is typically the way that this disease spreads throughout the body and causes lots of harm. We talk about stages of melanoma, and again, important for patients. If you unfortunately get diagnosed with melanoma and you've had a biopsy and you're being sent to us as surgeons, you will see a biopsy result with a T designation of your tumor, T3, T2, T4. That is generally not stage. I have a lot of patients that come to me panicking saying, yeah, I've got a stage 4 melanoma. Can you help me? And it's like, no, you have a T4 melanoma, and that's what your biopsy shows. We'll get your stage after surgery. Patients are not staged until after surgery. That's important. So talk to your oncologist about that. But when we talk about stage, we go from 0 to 4. 0 is melanoma in situ, and that's not on this chart, and that is almost always cured with surgery. Stage 1 melanoma is often cured with surgery. Stage 2 does better, and then does worse. And as you can see here, as the numbers increase with stage, so does the prognosis decrease. And we see that generally, we think stage 1 and stage 2 melanomas do well, but actually an alarming statistic is that over half, about 60% of patients who die of this disease actually presented with stage 1 or stage 2 melanoma at the time of diagnosis. So it's a funny disease in that sense. You talk about breast cancer. Early stage breast cancer is often cured by surgery, and stage 0 breast cancer patients often do very well, and stage 1 and stage 2 breast cancer patients don't account for more than half of deaths. So melanoma is different. I'll explain why in a little while. Margins are typically, we usually say about 2 centimeters. We don't go beyond that, and your surgical oncologist will talk to you about that. There's a move towards doing a little bit less. And then we get into some other cancers. So what do we need to do for other cancers? Well, we talked about melanoma, the pigmented cells anywhere in the body. We also have squamous skin cells all over our body. We have those along mucosal surfaces. They are kind of the barrier to the external world, and they're constantly changing. And that epidermal layer, when it transforms to cancer, is called squamous cell carcinoma. It's actually much more common than melanoma. We see about 100, typically 100,000 cases of melanoma. I think it was just above 90,000 last year. Prior to that, it had been in the 150s. So we saw a significant decrease, but squamous cell carcinoma, we're talking well over 2 million cases. So it's very common, and there's actually twice as many deaths. Everyone thinks of melanoma as more deadly, and it is per patient diagnosed, but when you look at the sheer numbers, there's twice as many deaths because we're talking a couple of million cases of squamous cell. Generally related to sun exposure, chronic sun exposure over decades, chronic inflammation. Sometimes you get squamous cell carcinoma in areas that are chronic wounds or ulcers. We generally do 1 centimeter margin, typically not a sentinel node biopsy, and differentiation and depth of invasion is super important with this disease, and the pathologist will help us as skin cancer doctors to treat this based on the initial biopsy. The most common skin cancer by far is basal cell, and this is kind of typically in older populations above the head and neck, sun-exposed areas, generally virtually no chance for spread. I wouldn't say zero, but close to that. But untreated can be a very, very, very problematic cancer and can invade bone, can invade cranium, can invade cartilage, really disfiguring. It's a curable cancer when treated early, but can really get out of hand if left untreated. Typically treated by our Mohs surgeons, who are really our gifted dermatological surgeons that can assess margins real time and get this done in offices. So this is typically what we recommend sent to Mohs. It's in addition to squamous cell. Merkel cell is a more rare cancer. It's a kind of cancer of the neuroendocrine or hormone producing cells of the skin. That's only about 1,800 cases per year. Super rare, can be aggressive, and we treat it with 1 to 2 centimeter in a sentinel node. I'm going to go into some surgical techniques that we do, and some of you on the forum here may have been actual patients that have had this done, but a typical ellipse involves removing the tissue, doing an ellipse along the longitudinal axis of the limb, and then we typically close that primarily, meaning we bring it together. And I almost never do skin grafts. I was trained by a plastic surgeon at Yale by the name of Steve Arian, a kind of visionary in reconstruction, and he taught me you almost never need to do skin grafts aside from a few areas. And those areas are typically the shin and the parts of the hand and sometimes the nose. This is a skin graft on the scalp, and you can see he's not my patient, but you know, typically skin grafts never look normal. Full thickness look better, but you know, if they're hair-bearing area, unfortunately, this guy seems like he's lost that battle a few years ago. But if you have hair-bearing area and you put a skin graft there, that doesn't grow skin. That doesn't grow hair typically. So if you can move tissue around, which you can into an amazing amount on the scalp, you can often preserve patients' hairline. Some areas are tough and you just have to do skin grafts, and this is the web space of someone's finger, and you can see here skin graft was placed after excision, and you can see that's a full thickness skin graft. That patient did well. Hands are very vascular, typically heal well. Face is very vascular, heals fairly well. This is a patient who had a deep melanoma of the leg, and you know, some of these pictures may be a little graphic, but this is what we do, and this is, I think it's important to show folks our reconstructions here. And this is an excision, and this is the tumor. This comes out, and this is her reconstruction, and she was quite happy with that, and she healed really well. We have to go down to muscle with melanoma, and you know, I think that's an important concept, that you go down to fascia, because this cancer spreads through lymph nodes, and if it gets into the dermal lymphatics, or the tiny little channels there, we want to make sure we capture that when we excise that. So a lot of our patients will say, well, I've had the biopsy. Why do I need to see a surgical oncologist, a head and neck surgeon, or why do I even need to go to a Mohs surgeon? Well, because you've not had margins assessed. You've not had the appropriate cancer operation. It's often hard to close one of these defects. So sometimes we turn a circle or an oval into and this is all geometry from, you know, from 8th grade, but you basically turn, and I find it very exciting to reconstruct patients in a way that will preserve their function and give them happy cosmesis generally. You can turn a circle into a rhomboid, and then you extend the short axis, and you can actually bring a flap over. And this is just to show you that we talked about melanoma as being very aggressive and very the most deadly of all skin cancers, but I mentioned basal and squame earlier, and I'm about to show you a picture here of a basal and a squame, and you could see how just alarming this is. These are large tumors. So don't just say that it's a basal cell and they're tiny. Again, we're able to reconstruct these most of the time with the help, sometimes of our plastic surgeons. This was with the help of Dr. Bossert at the time. Sometimes we have tumors across joint spaces, and that can pose a different challenge. And here we have kind of what we call opposing yin-yang flaps, where we take the melanoma off right on the lateral aspect of this patient's left knee, and then we raise flaps inward or kind of clockwise, and that reconstructs that without a skin graft. Sometimes one rhomboid's not enough. So you basically make a 120-degree angle here, and you can make 3 rhomboids, and you rotate these in, and this is really helpful in scalp. And this is a woman whose nose is here, and this is her eyebrow, and you can see the hairline right here, and she had a melanoma right here. And if I put a skin graft there, that area will never grow skin. That's never grow hair. So we were able to rotate these tissues in, and she healed very well, and her hairline again is right here. She actually never saw her scar. So almost like scarless surgery. This is a patient had a very thick, this is his back, he's on his side, a very thick tumor, and we were able to, again, remove this large tumor from his flank, and we rotated tissue in, and he did quite well. It looks funny while it heals, and this is someone's forearm. Their hand is wrapped here, and this is the dorsal part of their forearm, but skin stretches over time, and a few weeks later, his hair is growing on his forearm, and he's very, very happy with that. So this is why it's important to see a specialist. Sometimes you do complex excisions of someone's scalp, and you can see here, we excise this, we bring it together, and this patient actually has preserved hair line after surgery for a large lesion of his scalp. Sometimes we do skin grafts, as I mentioned, and this is a part where we did it on his hand with the help of our plastic surgeons, but this patient had a melanoma of the palm. We removed it, and we actually took muscle and skin and did a flap and pulled that to his palm, and then skin graft this area. Lymph nodes are important for the true staging of this disease. I think we're starting to see less of a role, much like breast cancer, but historically we use lymph node biopsies to say, hey, there's cancer in the lymph node. The stage is different. That's a poor prognostic sign. Maybe let's get the patient on an aggressive plan. Maybe let's get them immunotherapy. Let's follow them closely. It's a poor prognostic factor, meaning it's not something we favor if disease has gotten to the lymph node. We think in many patients, although there's some new evidence that a little bit of disease in some of these nodes actually wakes up the body, and this is a disease that the immune system can recognize. And we're starting to realize that maybe we're doing, at least I can say as a surgical oncologist, we're doing too many of these sentinel node biopsies. So I think you're going to see these starting to go away, and we're using specialized tests now, or fingerprints of tumor, genomic profiling, or GEP, to say this patient has a bad melanoma, this patient has a well-behaving melanoma, because melanoma is not just a one-size-fits-all. And it was just like COVID. Some people got really sick. Some people didn't even know they had it, and other people had a sinus infection. The same thing with cancer, and everyone has a different response to disease. This looks at lymphatic channels and finding lymph nodes, and you can see here we use blue dye and we inject it, and you saw that in some of the other pictures I showed, but you can see lymphatics here, and these are what we identify when we're looking for sentinel nodes. The sentinel node is typically the first lymph node that the cancer would go to theoretically if it were to spread. And if we remove that sentinel lymph node, we can say, okay, there's cancer in that lymph node or there's not. And then we can appropriately stage that patient. The problem with that theory is I tell my patients, cancer doesn't read textbooks. So cancer doesn't say, okay, the book says I need to go to the sentinel node, and then I'll go to the liver, and then I'll go to the lung. And that's not how it works. Cancer does its own thing in different people, and we all have different lymphatics. So the sentinel lymph node being positive means a lot in some patients and very little in others. And we're trying to figure out that mystery. When disease has spread everywhere, and here's a PET scan, you can see this is just peppered. All these black dots, you can see the skeleton, obviously, you can make that out. But these black dots are all melanoma. They're all disease. And when I was a trainee, this was a disease that killed almost everybody with metastatic melanoma. In fact, in the 1970s, there was nothing for stage 4 melanoma. Prior to 1998, there was just dacarbazine chemotherapy. And chemotherapy really doesn't cure many cancers. And that's a kind of a little dirty secret in the world of oncology. Chemotherapy prolongs disease progression in many cancers and helps many cancers, but doesn't cure many cancers. It cures many leukemias in children. It cures choriocarcinoma in women. It cured Lance Armstrong, germ cell tumors, but it doesn't cure many cancers. That certainly doesn't cure melanoma. So what did we have for stage 4 melanoma? Well, now we have immunotherapy. And just like it sounds, it uses the body's own immune system to recognize this cancer, which is immunogenic, meaning the body can recognize it. And we use drugs to kind of awaken the immune system. Because another little fact that people don't like to hear about is that everybody on this planet, everybody on this call has had cancer before in their life, everybody, whether you've had the actual diagnosis or not. But we have it at the 1 or 2 cell level. And our body has a system in place to say that cell's not normal. We have machinery in place. We have quality control. And that's happening all the time. We just don't realize it. It's when that system becomes slow or old, or we are now 60 or 70 and we've had exposure to tobacco or UV radiation in the case of skin cancer, that our chances of that getting kind of past our quality control system happens. But so we have non-specific immunomodulation, active immunomodulation. We have intralesional therapy, adoptive cell therapy. I'm going to go through these. These are kind of the classic categories of immunotherapy. High-dose interleukin-2 is one of the original. It's basically miracle grow for T cells. It was first identified in the 1970s by my mentor, who worked to produce a recombinant interleukin-2, meaning we could now manufacture this substance that was a miracle grow for T cells, for lymphocytes. These are cells that recognize foreign things in the body, like viruses, like infection, and in this case, cancer. So it was recognized early that the T cell played an important role in recognizing cancer, and could we boost its response by giving patients interleukin-2? And we did that at the NIH with my mentor, Steve Rosenberg, and we treated over 280 patients. And Dr. Rosenberg actually made the front page of Newsweek then. And he treated over 60 patients. Nobody responded. And it just shows you it was a different time then. He continued on that steadfast path. He knew that this would make a difference. And I believe this woman was the 63rd patient, and she had a complete response. All of her melanoma, which has spread throughout her whole body, lung, bones, went away. And this is her today. She's still cured. The problem, and this is Dr. Rosenberg's book, The Transformed Cell. The problem with this interleukin-2 is the response rate is low. It's very effective in a subset of patients, but we're talking about 7%. So 7 out of 10 patients will have their disease go away completely. And that's usually for life, but that's only 7 out of 100. So that number is kind of low. About 10 out of 100 have kind of a partial response where the disease goes away a little bit, but not completely. And that's what we had for a while. And then someone had the really groundbreaking discovery and insight to say, let's not try to put kerosene on the fire. Let's not try to promote things to work better. Let's see if we can get rid of inhibition, if that makes sense. So the analogy there is, let's not just put kerosene on the fire to hope it gets bigger. Let's take out every single water hose in the area. Let's make sure all the fire departments are closed. And that's the idea of taking the brakes off the immune system. You take away the inhibition, and then the fire can thrive. So this is a complex cartoon, but it basically shows you how cancer is presented to these T cells. And that's kind of what we call a peptide here. And that's given through this interaction. But we recognized that it wasn't just that interaction that was needed for the T cell to get excited and recognize the cancer. What had to happen was there was co-stimulation. You needed kind of these other molecules to interact. And When T cells get too active, anybody that suffers from rheumatoid arthritis or any kind of arthritis or any kind of autoimmune disease knows the problem there. When T cells get too active, they start to attack your own cells. And that's the problem with diseases like immune-related colorectal diseases like Crohn's. And so what can you do to kind of mitigate that? Well, somebody had the genius idea to put an antibody there, a blocker, so that now you have something that will stop this B7 from interacting with a molecule in the T cell. And instead of these T cells being shut down, because the body has a system in place to shut down T cells that get too active, so we don't all have autoimmune disease, and that is the CTLA-4. So somebody had the genius idea to say, well, let's block that. And when that happened, you got amazing responses in many, many patients. And that was the basis for ipilimumab. And these are CAT scans here, and you can see that just go left to right, and then you can see that you'll go down, and the top is post-treatment. So you can see here, this disease grew somewhat. This is groin, this is bladder. And then when you go down after treatment, and we're talking 9 years later, this tumor right here should be here, it's gone. This tumor here, again, gone. Tumors that were in, this is a cut of someone's, a cut of a CAT scan of someone's lungs. This is a tumor, this shouldn't be here. It's gone. 8 years later, still gone. This drug crosses the blood-brain barrier. You can see tumors here in the brain. The arrows are showing you, they're like little pearls. They shouldn't be there. Post 5 cycles, they're gone. And this was groundbreaking in 2010. And the FDA approved the first immunotherapy to show a survival benefit for patients with melanoma. And that changed the world. And now you can't find a cancer really on this planet that doesn't have an indication for some form of immunotherapy, but melanoma was the original. If you have time and you have Amazon Prime, Jim Allison, Dr. Allison, who is a Texan, was at UC Berkeley, then was at Memorial Sloan Kettering, and then proudly my alma mater for training, MD Anderson, won the Nobel Prize in 2018 for his discovery of anti-CTLA-4. He shared this with Dr. Hanjo of Japan for his discovery of anti-PD-1. And this is the story of bringing this drug to big industry, because that had never been done before. And it's pretty moving. There's a lot of patient testimonials there, and it's narrated by Woody Harrelson. It's amazing. If you take the brakes off the immune system, you can imagine what the side effects are. The immune system is too excited. And if that happens, you get, guess what? Autoimmune disease. So every itis, pancreatitis, colitis, dermatitis, and some of these are pretty significant. Some of our patients have pancreatitis and become autoimmune related insulin insufficiency, and some have become diabetic. We're realizing now the interactions are so many, and it's so complex, and it's not just one signal. So this is just a cartoon showing you the interactions that we think are happening at the cellular level in cancer. Anti-PD-1 is another drug that, again, takes the ability of the cancer to the cancer is trying to camouflage itself from the immune system, and this exposes that. It takes that sheet right off and says, hey, immune cells, that's where the cancer is. Cancer vaccines work well in certain cancers like prostate, and I think you're starting to see a revival of them in melanoma, especially with mRNA vaccines, and I think the data is pretty compelling there, but there's more to come on that. Sometimes we inject tumors with what we call intralesional therapy, and we'll talk about kind of this TVEC concept, which is fascinating, and again, a different form of immunotherapy. It's a herpes virus that is stripped of its ability to replicate. It has been gene modified to express a protein that enhances kind of inflammation in the area and says, hey, you inject it into the tumor in the clinic, and it's given with a different type of immunotherapy, and it says, hey, immune cells, come here. This is where the party is, and that is how it gets the immunotherapy to recognize the tumor. It's really can have some pretty compelling responses and off-target effects, meaning it doesn't always just affect the tumors that you inject. Sometimes other tumors go away as well. So really exciting. And this just shows you what has happened over the last 40 years. We have so many drugs now in our armamentarium. We have immunotherapy, we have targeted therapy, we have TVEC, we have intralesional. There's been a complete change in how we treat this disease, so that in 1990, only a third or 30% of patients who had melanoma would live for 1 year. Now, we're seeing patients who live a year. You know, that's almost 85 to 90% of patients with metastatic melanoma will live at least a year. That's a monumental increase in survival. And some patients with metastatic melanoma have become almost chronic disease patients. So we'll finish with this last concept, I think, of adoptive cell therapy. And this is something that's very near and dear to me. There is a company trying to bring this to the United States through the first FDA-approved product. And we're going to see that in the next few years is my hope. But it's a beautiful concept born out of research we did at the NIH. And I've tried to bring this to Rochester, and hopefully it will come someday. It says, the concept is you've got melanoma everywhere in your body. Can we take one tumor off, not remove every tumor, take one tumor off, you go home, recover. We take that tumor to the lab, we try to get the good lymphocytes out, the good immune cells out, we make sure they work, we replicate them to billions, we bring you back after you recovered it and we put them back in you. It's basically a lymphocyte transplant for yourself. And you see amazing responses with this. We call it TIL, or tumor infiltrating lymphocytes. Tumors are gone. We see response rates anywhere from 30 to 70%. Some patients are cured. One report out of the NIH showed a complete response rate of about 15%. You can see here, again, tumors in the mediastinum around the heart just gone. Lung tumors gone. And these are the faces of melanoma. So left to right, Bob Marley had aquilitiginous melanoma, unfortunately died of melanoma. We lost a great musician. President Jimmy Carter is still with us. He had metastatic melanoma to the brain. He got ipilimumab, anti-CTLA-4, is cured, last I checked. Senator McCain had melanoma, I think 3 or 4 times, actually, and eventually succumbed not to melanoma, but was a survivor of melanoma. Jim Johnson, former defensive coordinator of the Eagles, who actually Sean McDermott actually took his place when, unfortunately, Mr. Johnson died of metastatic melanoma. And as odd as it sounds, our Bills head coach, Sean McDermott, is a melanoma survivor. And Danny Federici of the E Street Band, unfortunately, died from melanoma. So too many people had died of this disease, and at least we can say that President Carter is a survivor from the advances of immunotherapy. So in summary, melanoma is rare, but remains on the rise typically. Avoiding excessive sun exposure is crucial. No tanning beds, please. I would say minimum SPF of 30. We typically do excisions and sentinel nodes, and you often need to see a surgical oncologist, whether that's a general surgical oncologist like myself or a head and neck surgical oncologist. For other skin cancers, squam, basal cell, we typically recommend that a Mohs surgeon is consulted. And immunotherapy is a living and effective treatment that has really revolutionized the treatment of a previously deadly cancer. I'll stop there.
Well, Dr. Prieto, I would like to thank you. This presentation was amazing. I particularly found it very insightful and helpful as a child of the New Jersey shore and lots of sun exposure. I found this very relevant, and it'll please you to know that I do see a dermatologist every year. And also, the next time my 8th grader tells me he's never going to use geometry, I'm going to tell him about Dr. Prieto. So absolutely amazing. And I'm pleased to say we've got about 10 questions in the chat box. So I'm gonna do my best to get us through as many as we can with the time we have allotted. So our first question is, what are the preventive clinical guidelines and key educational messages for patients to ask their primary care providers?
Typically things we covered here, what type of SPF coverage, sun barrier methods. There's now a whole line of UV. Actually, Sean McDermott, again, the Bills coach, has his own line of UV protective clothing, long sleeves, and it's very breathable now in 2023. I mean, you can have bathing suits that dry quickly when you come out, and you can play golf in long sleeves, and really still there's breathable materials, but hat, sunblock barrier methods, and, self-examination is crucial. Like, again, in breast cancer, self-examination is crucial there. But with skin, I always say with your partner, make it kind of a date night. You guys can look at each other's backs, and these are areas we don't see. And in women, the most common area is legs, and men, the most common area of presentation is back. So, and the other thing I recommend, the last thing, is take pictures, because you won't remember. It's like watching the grass grow. Sometimes you won't remember if that mole has changed. So take a picture, and then if you think it's changed, take a picture a month later and you compare it.
What a great suggestion. Thank you. We do have, as all of us battle with misinformation, I think this next question is particularly helpful. So what would you say to someone who doesn't wear sunscreen because they believe it causes skin cancer? How would you address something like that in a patient?
Yeah, there's never been any reliable data to support that. Generally, we think that chemical sunscreen, at least I think, it's just a little harder on sensitive skin. But zinc oxide is very, very safe. Mineral-based sunscreens are very, very safe. I mean, the benefit of using sunblock is far outweighs any kind of risk you would have from any chance that it would cause harm. I've never seen a case of anything, any cancer caused by sunscreen.
Great, thank you. This is a pretty good one here. How important is it to use the sunscreen that's within the expiration date listed? My wife and I have this conversation about pickles all the time. I say they're already pickled. It doesn't matter if they continue to be pickled for another couple of months. So should all expired sunscreen be discarded immediately, or is it okay to use it beyond the expiration date?
Personally, I think if there's some wiggle room there. I think if you had it last summer and now it's the next year, I use it personally. I think it's for you. If you were to find a box of sunscreen in, say, a department store that shows a date of 6 years ago, then I think, so anything over a year, I think I may not use just because of decreased efficacy, but there's some wiggle room.
Good to know. Thank you. During my yearly skin check, my provider mentioned in passing that there's a debate surrounding basal cell carcinoma. What I think I heard is that experts are questioning if this is really cancer. Can you elaborate a little bit on that?
Yeah, it's definitely cancer. Cancer is just defined as uncontrolled cellular growth. The tumor, the cells do not know how to turn off anymore. They lose their ability to recognize those signals. And with advanced basal cell, you can see this erode through someone's skull and they can have exposed brain. They can have exposed sinuses. Their sinuses can absolutely kind of implode on themselves, and only cancer can do something like that.
Okay, so do people of color have to be concerned about getting skin cancer? And how would you recommend using sunscreen for patients with darker skin pigmentation?
In an identical way. I think a misconception is that people of color have a decreased chance, and I mean, Bob Marley is your key example there. We see less cutaneous skin cancer in people that are more pigmented. I have some South American background in my father is from Colombia, so I typically, and you'll hear people say this, I tan well, so I need to worry less about this. Not true. I mean, I get less sunburns, but I can still get melanoma, and people of color, especially African Americans, can get skin cancer, and we see that. And I would recommend they use sunscreen in a similar way that Caucasians do. Okay,
certainly good advice. I think you answered the next one about the genetic component of skin cancer, and first degree relative is considered an increased risk factor.
Absolutely.
This one came from Bruce Campbell. There are new diagnostic products now, specifically patches, that can be used to extract cells for testing and are less invasive than the typical taking of a sample and sending it to the lab for testing. Are these new approaches as accurate And do you see a broader use of these in the future?
No, I think I've seen that technology. I'm not a big fan personally. I've seen them miss some skin cancer. I use kind of the eyeball test, as I say. If I look at something more than 3 seconds, I biopsy it. I don't use a piece of Scotch tape, as we kind of refer to it in the industry, as helping me say that this lesion needs a biopsy. I think there's a big role for genomic testing, or GEP, and we touched on that. And that's saying you have melanoma now, but let's do a background check on your melanoma and see if it's a bad player or a good player. And I think there's a big role for that.
Wonderful. The next is, are certain races or ethnicities more prone to certain skin cancer types than others?
Yeah, generally Caucasians, melanoma, squame, basal. I almost never see melanoma in South Asians. So people of Indian, Sri Lankan, Nepalese, I've never seen melanoma in that population. I've seen some squamous cell. Those people, Nepalese, often live in higher altitude, and the sun exposure, that's another good point too. I don't know if we talked about that, but it's cold here. You get a lot of snow. So when you're in high elevation, when you're in snow, you have an even higher chance of being sunburnt in the winter.
Interesting. Does immunotherapy for certain melanoma cancers work for patients of all ages equally?
Yes, we think it does. It doesn't work for all patients equally, but there doesn't seem to be an age discrepancy. Patients with melanoma in general who are younger do worse, we think, because their melanoma is more aggressive. So that would play a role in that algorithm, but immunotherapy seems to be just as efficacious in young versus old.
And are you going to continue working with adaptive cell therapy? And if so, what are your hopes for this treatment in the next 10 to 20 years?
Yeah, that's an interesting question. I actually am. So I'm actually going to I will maintain an adjunct appointment at the University of Rochester, but I'm actually taking a leadership position in the next few weeks with a company that's going to commercialize adaptive cell therapy. And you're going to see that at major centers across the country. That time has been coming for the last decade. And you will see, I think, the first commercially available TIL product where you have an operation, you grow the cells, and that's given at big centers like University of Rochester Medical Center.
Amazing.
You have to remember one important fact there is, you've heard of CAR T cells, and 90% of people that die of cancer die of solid tumors, melanoma, breast cancer, glioblastoma, sarcoma, not the liquid tumors or the lymphoma. So 90% of people who die of cancer die of solid tumors. So there's a real need for that therapy.
Okay. And what's the outlook for ultraviolet over the lifespan? I've heard that the sun is stronger than it used to be. Will this affect our children or younger generations more intensely than it used to?
Yeah, we're looking at that. Personally, you know, I feel like the sun, just, even though it's only 7 degrees at some point, I remember it being 90 and I being a kid and having more tolerance than a 70-degree day now where there's no cloud. So I do feel like it's become more intense. The data is kind of conflicting. The ozone layer actually has repaired itself amazingly. So we think that there's some good things that have come out of kind of some implementation of some legislation against chlorofluorocarbons, but climate change, you know, unfortunately is real, and we're seeing warmer temperatures and summers will become more intense. So it's that early sun damage, that early sun exposure as a kid that's crucial to prevent.
Great information. Well, that concludes our question and answer section. We've answered all the questions that were in the chat. So I'd like to thank you, Dr. Prieto, for the presentation today, and our panelists for joining us today. I'd also like to thank our interpreters for helping to make this accessible for our deaf community. I'd like to remind all of our attendees today to please be sure to fill out the survey following the webinar to make sure that we continue to provide content that you're interested in hearing about. This webinar has been recorded, and an email link to the video will be sent to all registrants early next week. If any additional questions come in, they'll be answered in that follow-up email. So I'd like to take the opportunity to invite everyone to join us for our next community conversation focused on liver cancer, which is June 15th at 12 p.m. So with that, I'd like to wish you all a fantastic remainder of your day, and thanks again for joining us today.
Thank you so much for the opportunity. Have a great day.
Bye now.